I am really pleased to introduce Dr. Javier Valle, who is an interventional cardiologist at St. Joe's in Ann Arbor. He has graciously offered his time to talk to us a little bit about bleeding related to PCI, to kind of give us some of that why behind, the fields that you abstract on bleeding and some of the ideas behind why we made this a P4P goal this year. So I will hand things off to Dr. Valle, and thank you so much. If you have questions, as Kathleen said, please put them in the chat.
Great, thanks for joining me today, everybody. Thanks for inviting me to this to your forum. So we're going to talk a little bit about major bleeding. As Emery said, I'm an interventional cardiologist, so this is, unfortunately something that I cause with the things that I do and the mechanisms and medicines that I use. Greatly despised. So it's an important quality metric to look at. So we'll talk a little bit first. So I have no relevant disclosures, but basically just talking about the structure of the discussion here. First of all, just how we define major bleeding, how BMC does, and how this has been defined previously. I think it's important to kind of talk about the historical ways in which we looked at it, why the decisions have been made to look at it in the way that we do. How does bleeding occur after PCI? What's the frequency? What's the etiology, the cause? And then what is the significance of the major bleed? So what happens to our patients when they actually have these bleeding issues? And then finally, what do we do as far as bleeding avoidance strategies? How do we try and limit these things from happening? So first, let's talk about definitions. Major bleeding has been defined in multiple ways in the literature. There's the TIMI bleeding risk score, or sorry, TIMI bleeding categories, major, minor. There's gusto bleeding, there's BARC bleeding, ISTH acuity, GRACE, multiple kind of acronyms there that basically ends up being essentially an alphabet soup of ways in which that you can define bleeding. The key thing that's been trying to be developed is basically a way to standardize definitions so you can compare them across studies, you can compare them across patient populations, you can compare them across institutions. And so what that means for registries, because you're looking at, not just clinical trials where you have, paid adjudicators, not just, basically that are there for a certain small number of patients in the clinical trial. Registries need to have an even higher bar, I think, that requires true reproducibility, because you don't necessarily have an adjudicator for each patient looking, tracking things down, going through, the charts and calling patients and doing these things to try and get some of the things that they can accomplish in clinical trial work. So, these definitions matter. You need to be able to stratify bleeding, no matter what the severity, understanding what the severity is across operators, across institutions, and across patients. And so what that means is, again, coming down to reproducibility. So what you need then is objective parameters, things that you could look into the chart and say, okay, this is an objective parameter. It says your hemoglobin went from this to this. That's an objective parameter. Your heart rate went from this to this. That's an objective parameter. So those lab parameters are things that we can look at and say they're measured the same way across institutions. This is the number that we look at. The change in number is a change in number. It's an absolute. We need to have minimal reliance on subjective terms. The subjective things like life-threatening bleeding, which is one of the things that's actually included in some of the risk mod and some of the scores. That's fairly subjective. If you think about what life-threatening bleeding means, that can be variable. If someone comes in with a hemoglobin drop of 7 grams per deciliter, their heart rate's 95, their blood pressure is 100/50, and you have a similar patient with a 7 hemoglobin drop and their heart rate is 105 and 89/60. Not that clinically different, but which one is a life-threatening bleed? That's a subjective assessment, and that's really hard to communicate in a registry. Or then other definitions that include causing substantial hemodynamic compromise. Again, you look at those two patients, similar vital signs. One might be substantially hemodynamically compromised, one might not be, depending on who decides to look at the patient. When we talk about transfusions are something that you can check, right? It's an objective thing that you look at. Did someone get blood? Did someone not get blood? But then think about what led up to that transfusion. Someone made a subjective decision, because we have pretty minimal guidance as far as when to transfuse patients based on the data that we have. Someone made a subjective decision of, yeah, that guy probably needs blood, and made that decision. So even then, when those objective findings are there, a transfusion or not, it comes down to a subjective decision that, really can influence what we're defining as far as our outcome. So again, these definitions are carefully thought out to try and minimize the subjectivity of it and try and leave you with an objective kind of assessment of There is a bleed, there's not a bleed. So the BMC2 definition is basically about as straightforward as it gets. Hemoglobin before and after. The baseline hemoglobin, then the lowest hemoglobin within 72 hours, subtract the two, and if it's greater than 5, it's a major bleed. Certain specific things are excluded. For example, if the patient goes on ECMO, sure, that's excluded, but the rest of the procedures are included in here, and that's straightforward. Now, where did that 5 gram number come from? It actually came from probably the TIMI bleeding score, which is one of the most common used in the cardiology literature. It was originated basically in the thrombolysis and myocardial infarction studies, which date back before my time in medicine, but basically used a 5 gram hemoglobin drop as a major bleed. And that's been reproduced and studied and extensively used throughout the literature. And so that's basically the choice for what we see. Maybe it might be an arbitrary number, but it's based at least on some data that we have and reproducibility going back with multiple major studies. So any questions about the definitions? So the question is, how are these patients being categorized as a major bleed with drop of 5 or more with no bleeding and transfusion? So if your hemoglobin drops by 5 points, by 5 grams, it's hard to do that with anything but a bleed. People talk about dilution, people talk about, massive fluid resuscitations. You might see a 1 or 2 gram hemoglobin change with that. And so, the 3 gram hemoglobin cutoff has been kind of batted around a little bit about whether or not that's truly accurately reflective of bleed. But if you drop 5 grams, there's something going on. There's blood loss. So it's a pretty high bar to hit. And one might even argue that it's relatively less sensitive than some of the other bleeding scores that are out there and other bleeding assessments that are out there. For example, ISTH, one of the other bleeding assessments, is extraordinarily sensitive to the point where, if you have a bleeding event that causes you to come back to the ER for anything, for a nose packing, that gets counted as a minor bleed. I don't think that's what we're looking for. That's not what's necessarily correlated with the severe outcomes for patients. Other questions? Okay. So, post PCI related bleeding. So historical data characterizes bleeding as happening about 3 to 6% of all PCIs. Now that's in the early 2000s. That's before the radial revolution. That's before some of the changes that we've made to our antithrombotic regimens. Some of the things that we've done to try and decrease sheath size, the size of the access point, and some of the things that we're doing to try and minimize bleeding now that we recognize how severe of a problem it is. In the contemporary literature, in the real world, estimate somewhere between 1 and 2%. So it doesn't seem like there's huge numbers, and I think it's attributable to some of the factors that we see here. There's been pretty significant technological advances, so smaller bore catheters. So instead of using 8 French systems, we're using more 5 French and 6 French systems. Instead of going from the femoral artery, where there's significantly higher rates of bleeding, we go from the radial artery in increasing numbers. And then anticoagulant strategies. We used to use 2B3As pretty consistently because we had questions about the antiplatelet efficacy of loading patients with Plavix early on, because it just didn't have a rapid onset. I think those numbers have gone down significantly because of the bleeding rates that have been shown with 2B3As, but also with the more potent antiplatelet agents that we use, where we think that our antiplatelet inhibition is earlier in onset, so we don't have to slam patients with every single way that we know how to inhibit their ability to clot. So when do patients bleed? It's really kind of bimodal. There's, immediate in the peri-procedure or at some point later. So you kind of have this immediate sort of procedural related bleeding where you have groin bleeds, access bleeds, bleeds related to the heparin that you give in the procedure, or there's bleeding thereafter where they have complications basically later on during their hospitalization or even after they leave related to some of the medicines that we use to keep their blood thin after we perform PCI. Where do patients bleed from? And again, these kind of 2 different ways to think about it. There's 2 categories. One is access site bleed. So where we poke the hole, did they bleed? Or is there basically antiplatelet or anticoagulant related bleeding, and where is that coming from? And that can happen in a variety of locations. So again, when or where do patients bleed? We did an analysis here, basically looking at the incidence of bleeding and bleeding-related hospitalizations. You can see this data here shows basically all bleeding and then broken down into category. And you see this initial spike early on, and then as you go forward, even leaving the hospital, patients can bleed from a variety of other places and variety of locations that aren't access-related bleeding because of some of the things that we do to them. We do to their platelet function. We put them on blood thinners for a variety of indications, but this is important for our patients. So what does that mean? We talked about bleeding outcomes and bleeding is bad. We all kind of understand that, but let's put a number to that and see what that means. So why do we really care? Over the last 10, 15, 20 years, there's been multiple publications looking at severe bleeding and the impact of bleeding on outcomes. And as it turns out, it's all really bad. If you have a major bleed, post-PCI bleeding is associated with adverse events, both in hospital and long-term. So not just while you're in the hospital, but it follows you. It actually follows you out to even greater than a year about bad things that can happen to you. And you can talk about whether that's related to the bleed itself or whether it's related to the patient. But ultimately, if you have a bleed, those bleeding events are associated with bad outcomes. And those outcomes include increased length of stay, which makes sense, readmissions for bleeding or for other causes, repeat bleeding events, myocardial infarction, and ultimately mortality. So all these things are associated with increased bleeding events, and they're not subtle associations. So let's look at where these data come from. There's some data from the clinical trial literature, but I think more importantly, actually, real world bleeding outcomes show what's really happening with our patients. So this is a study from the biggest study that we have from Cath PCI, about 3.4 million interventions from 2004 to 2011. So not 2020, but relatively contemporary as far as the data that we have. Bleeding event rates were 1.7%. So about 2% of all PCI cases had a bleeding event. And bleeding was associated with significantly increased in-hospital mortality. So with the NCDR studies, with the Cath PCI studies, you can only follow the patients out to basically when they leave the hospital. Before patients left the hospital, if they had a bleeding event, their mortality was doubled. That's a pretty significant event, right? If you look at that, all patients had with no bleeding had about a 2% mortality risk. It's up to about 5% if they have a bleeding event. And you can see by their bleeding risk, which gets categorized in various ways, the risk basically follows that same trend. This was another analysis of Cath PCI, this time looking at longitudinal outcomes. So in the subset of patients with Medicare, so older patients, you can actually follow them for about a year, if not a little bit longer, to look and see and look for Medicare billing codes and mortality. And what it showed was that, again, it didn't just affect patients in the hospital, but patients who had a bleeding event. And again, these are older patients, so higher risk for bleeding. It was 2004 to 2008, so a little bit earlier. Bleeding events were about 3%. As you looked at patients, this was basically, from their PCI to 1 month, from 1 month to 12 months, and then from 12 months to 30 months, so even greater than a year. All of these adverse events, so readmissions for bleeding, major adverse cardiovascular events, and mortality, continue to remain above baseline, right? So if you had a bleeding event as a Medicare, elderly patient, you were at risk for something bad happening to you well beyond your hospitalization and even going out to a year even going out to greater than 2 years. And then how about us locally? So BMC squared. So this was an analysis coming from BMC published in 2014, looking from 2010 to 2012, 96,000 PCI patients. So a lot of patients. And this was actually just looking to see, was there a gender specific risk for bleeding? I think the message overall is that bleeding is bad. Whether you're a woman or a man, the bleeding risk is elevated. The bleeding risk correlates with some increased risk of mortality. This is an assessment of expected to observed mortality. So if you risk adjust for the expected mortality of a specific patient, you have a certain number. And then what the actual expected mortality is for that patient is exceeding that number by a certain amount if you have a bleed. And as you can see on the right side, patients with post-PCI bleeding, their expected mortality was nearly doubled. No post-PCI bleeding, it was about the same. It's what you expected. So really, bleeding has a significant impact on patients' mortality. And then, what if the bleeding has nothing to do with the PCI? So I'm an interventional cardiologist. It can't possibly have anything to do with my access point. My access was perfect. As it turns out, non-access related bleeding is incredibly important as well. And so if you look at, this was the initial analysis that we looked at from NCDR with that, millions of PCIs, what they actually looked at was, again, the same question, was what happens if you don't have evidence of a bleed, of a hematoma, something like that. It's considered a non-access site bleed, and those are actually worse. So if you look at what the patients have here, access site bleeding, their mortality increases by some. Non-access site bleeds, so these are the intracranial hemorrhages, these are the GI bleeds, these are the rectus sheath hematomas, these kinds of things confer an increased risk of mortality as compared to access site bleeds alone. And I think the theory behind that is because when you see an access site bleed, you know how to deal with it, you know you can stop it. Sometimes that's a technical issue that can get taken care of. Non-access site bleeds have more to do with the patient, and they carry on the patient's risk. And so if you have a patient risk factor who's, a patient who's elderly, who's female, whose BMI is less than 19, who has chronic kidney disease, she's a setup for bleeding. Those are the risk factors that are there. If the bleed has nothing to do with the access point, then she's at risk for other bad things happening because of those risk factors that made her bleed in, whatever location that she is bleeding in. So in summary, basically, post-PCI bleeding is consistently associated with poor outcomes for patients. It's true both in hospital and long-term after discharge. Now, how do we prevent it? Let me just stop here. Any questions about that so far? Okay, so how do we prevent it? And that's up for debate, but I think, there's really two main buckets to think about. One are patient-related factors. These are age, female gender, extremities of BMI, so overweight patients, underweight patients, they're both at risk for bleeding, chronic kidney disease, prior anemia, all these prior bleeds, all these things predict risk of bleeding. Now, are any of these modifiable? No, they're not. They're part of the patient. You can't make an 80-year-old 60. You can't make someone with a BMI of 19 all of a sudden 24. You can't do these things to patients. But what you can do is select your patients carefully. And so I think, in the absence of acute coronary syndromes, when we're talking about stable angina patients, we're talking about stable ischemic heart disease, really having good, effective patient selection is critical to have a risk-benefit discussion about whether or not, their bleeding risk might be prohibitive for, an intervention. Other procedural-related factors that we look at, ACT monitoring, which we do a great job of, 2B3A avoidance or minimization of use, a transradial approach, what antiplatelet agent is chosen, what their regimen is, if they're going to be an antithrombotic afterwards with their antiplatelet, anticoagulant strategy during the case and afterwards, and then use of a vascular closure device. All these things have been debated. They all have benefits. There are varying data on whether or not anticoagulation strategies can impact bleeding, and there is unclear data on vascular closure device use as well. But these are all things that we look at and say, these might be able to interfere, lower the risk of bleeding in patients. And so we try and use them. But they don't necessarily get used in the right patients as part of the other problem. There was a very interesting study done in 2010 that looked at the use of what we thought were bleeding avoidance strategies, the main ones that we used at that time, among bleeding risk patients. And so what you looked at was, what was the strategy here? Again, this is mainly focused on basically procedural bleeding. And you looked at, okay, was there vascular closure device used? Was there bivalirudin, which has some data towards less bleeding compared to heparin and the 2B3A? And then were there vascular closure devices used? And so all those three things were assessed. And as it turns out, they were used fairly commonly. But if you go across the boards here, their numbers actually decreased as you got to higher risk patients. And so they were used, but then they were used more frequently in patients with lower risk. And so this is a paradoxical use of the bleeding risk patients, where we're using, the techniques to lower bleeding risk more commonly in the patients who are less at risk of bleeding. So again, this kind of Venn diagram of who's at risk for bleeding, what can we do to prevent them? And we really need to make them, kind of overlap a little bit more if we want to prevent bleeding. So in summary, major bleeding is associated with significant adverse events for patients that have PCI. They're associated with mortality, with MI, with repeat bleeding. It occurs both in hospital and post-discharge. So it follows you. It's a tail that will follow patients for over the year after their hospital discharge. As far as bleeding locations, non-access site related bleeding is actually worse than access site bleeding. Is associated with worse outcomes compared to access site related bleeding. Bleeding avoidance strategies do exist. I think, trying to use them judiciously, trying to use them in places where the patients are going to be at highest risk is the key thing. We all have these strategies that we can use. Are we deploying them in the right patients is really the big question. But I do think the most important thing that we can do to influence bleeding in our cath labs is really focus on patient selection. We can't do anything about the acute coronary syndrome patients who come in. Those patients need a cath; they absolutely need it. The patients who we select for stable ischemic heart disease, are there things that we can do to optimize them in a better way? Or are there other options for these patients if they're prohibitive risk? Those are questions that we have. So with that, I will stop and take questions.
Hi, this is Dawn Light from St. John Hospital. I tried to send a chat, but my chat question doesn't give me the submit button, so I'm not sure what's going on there. But I do have a question for you. I'm wondering if you have any data or thoughts as it relates to bleeding events and cases using mechanical support. And the reason I'm asking this question is because, as we started to look into this, we're finding that approximately half of our bleeding events are occurring in our patients with mechanical support. And I just didn't see anything in the NCDR reporting or in the BMC squared reporting that relates to mechanical support.
So we do know that mechanical circulatory support is associated with higher risk of bleeding. That's been demonstrated over and over again. And a lot of the things are again coming down to basically a combination of issues. One is that patients who require mechanical circulatory support are bleeding risk patients. They're coming in, with either unstable coronary syndromes, they're coming in with heart failure, they're coming in cardiogenic shock. They often have a lot of comorbidities that predispose them to bleeding. So that's one issue, right? So that's one strike against them already. Then the second thing is that you're putting an MCS device in, which is not your 5 or 6 French sheath. You're putting in a 14 French sheath in the groin, so you can't do it from the wrist. And so that creates a problem where you're basically taking high risk patients and you're exposing them to a high risk procedure. So the bleeding risk is going to be higher. Finally, does that answer your question? I mean, I guess, the thing is, it's something that I think we know, but we don't have a better option at this point.
Right. I mean, I guess my question more is, what's the expectation? I think, as you were saying, it's not really access bleeding that we're having issues with mechanical support. It's more of those other bleeds because of the anticoagulation required. And I'm just wondering, as far as benchmarking, what we should expect for that. And I know this major bleed P4P isn't risk adjusted, but for the sites that are doing high risk procedures with these mechanical support, is our percentage going to be higher than other sites?
I won't speak for BMC squared, but I mean, if you're using a large amount of mechanical circulatory support, it will be just by the numbers, right? But for it to influence the number of bleeds that you have, I mean, unless you're doing 15, 20% of your cases with MCS, it's not like 50% of those patients have a major bleed.
Okay, thank you.
Other questions? Anne-Marie, do you have any thoughts on the MCS question? Because it's an appropriate one. I think there's you're screening a high risk population and you're exposing them to a high risk procedure, and then often these cases, especially if they're done emergently, these devices are being put in urgently and quickly, and so the bleeding risk goes up with those patients. There's no doubt about it.
You're right, and I'll invite Kathleen to speak up as well. I think we've had that question certainly among our physicians as well, and I think Dr. Gurm's response would be, yes, we know that there is a higher risk, but I don't think we've seen any significantly higher rates at our sites that do a somewhat higher volume of those. So I think we can evaluate that, over the course of this year. And certainly, I think I can hear, you asking, is that going to affect our P4P score? Because we're seeing higher risk patients, and we can certainly keep an eye on that and consider adjustments if it's really skewing the data.
Well, we did consider that when we were creating the P4P measure. We specifically, that's where the ECPella and that's where ECMO was excluded, and the other mechanical support devices were not. I will say that our sites that use the mechanical support devices on a more routine basis. You have patients coming in electively, you're doing high-risk PCI with support. Those are typically our large volume sites. So they already have an advantage by having a larger volume to start with. But it has been, we did look into what to exclude and what not to, because we know this is all important. And so our physicians are aware. It doesn't hurt to, have discussions again, but it has been looked at. And even when we realized that devices have been added, I didn't have one of the ECMO, the ECPella, I didn't have that in the first place on the exclusions. Well, that's been added. So we do try to keep up with that kind of stuff, and our physicians are aware, but I understand the frustration I hear in Dawn's voice too, that like, wait, we know that they bleed with these, but we don't want to just exclude those patients as, as if that bleeding is not a significant risk factor for them. So anyway, like Anne Marie said, we keep on looking, so, and we appreciate your questions. We have another question I saw from somewhere. Why is the long-term mortality, why is there a long-term mortality risk with bleeding? Christy Todd asks.
So that's a really good question. This is one of these things where you can't randomize someone bleeding or not bleeding. There's no randomized trial to do that. And so these are all associations. So you can't prove causation that the bleeding is causing a problem. And I would say, what we're seeing is an association with increased mortality for the patient. So in my opinion, I think bleeding after PCI is really a marker of patient risk more than anything else. And so what you're seeing is, patients who are at higher risk for bleeding are older, they're lower BMI. So, they have lower albumin, they're just, not as functional, they have chronic kidney disease, lots of different things that can kind of contribute to their increased mortality. And the bleeding event actually ends up being a marker for those things. But I have no doubt in my mind that the bleeding itself transitions, and causes problems for patients. That's one thing. The second thing is that if you look at what happens to these patients when they bleed after a PCI, what's the first thing that has to happen is you have to get control of the bleeding. And all the things that we put patients on to protect them from cardiovascular mortality cause bleeding. So aspirin, Plavix, their blood pressure medicines, or metoprolol, their ACE, if they have a bleeding event, those tend to be stopped and they can get intermittently resumed. So all those things carry risk. And if you look at what happens to these patients, they have a bleeding event, they're on all their maximal antiplatelets, they get taken off for a certain period of time, then they get kind of put back on to some intermittent event, and it'll kind of come and go and come and go and come and go. And that we know is going to contribute to their risk. So I think it's a combination of things.
Thank you very much for that comprehensive response. I appreciate it.
Sure. Why Impella is not included, I cannot answer that. I'll kick that back to the group.
So I think what Amber's asking is, why isn't Impella not included on the exclusion list? Is that what you're asking, Amber?
I think that's what's suggested, yeah.
Yes, I'm sorry.
And I can't give you the specific rationale because I'm not a physician, but I will tell you they specifically were addressed device by device. We did go through Impella versus Impella CP, the variety of Impellas, the smaller versus the larger, volume, the 5 liter versus the lower liters, and they were not excluded. So I can ask for more specific clinical rationale, but ECMO was a definite, because they're on total support at that time. They are excluded.
To say that, Kathleen, maybe we can ask for more specifics and share that back with the group, either in follow up on email or at our next meeting.
Yeah, because Dr. Valle wouldn't have been the decision maker for our definitions, but I will tell you it's not an oversight. So, but just so you have either rationale to take to your physicians or rationale to satisfy yourself. People with registries, we all want to attribute cause, and in registries you can't attribute cause. Like I know when my physicians, they would say, this is not my fault, as Dr. Valle alluded to, this is not BCI related.
It's never the interventionalist's fault. That's
Well, and is there really fault, or is this, just a bad situation? The patient's ill to start with. We try what we can to help them. And I've noticed a lot of our sites are using those bleeding risk scores, but are we really implementing the bleeding avoidance measures when they have a high bleeding risk score?
Ultimately, we need to achieve patient safety, right?
Right.
So we need to keep patients safe, and to some degree, there's not a bleeding. Trying to achieve a bleeding score of 0 is impractical, because at that point you're gonna be risk averse. You're gonna say, I'm not gonna take anyone to the lab who's gonna bleed, and I'm only gonna do 500 procedures and never put an impella in. So the risk, I can't say what the right number is. There's no, it's whatever number is out there. There's going to be room for debate on what that number should be. But at the same time, there needs to be some way to assess to make sure that we're doing it the right way. No one's saying that these patients shouldn't get it, but there should still be a goal to keep bleeding minimal. You can't just say that, I'm going to put an impella in, so I don't have to worry about the patient bleeding because they have an impella in. That's counterintuitive to the quality process.
And this is Dawn Light again, and I think my question was a little bit misconstrued as to worrying about the pay for performance. I'm actually exactly what you're saying is I really like to see this mechanical support broken out so that I can know if we have opportunity for improvement there, if there's a best practice that we're not doing. So I really like to see, and I know I emailed Kathleen this, and we've been talking, some benchmarking on that and maybe some data on that, where I can know if our mechanical support, should not be having the bleeds we're having, or if that's normal. That's basically what we're trying to figure out.
I think that's an excellent point.
Sorry to put words in your mouth, Dawn. Thank you for clarifying, and we will work on that data request.